Thank you so much for having me. My name is Amir Fathi. I direct the leukemia program at Massachusetts General Hospital, and I'm an associate professor of medicine at Harvard Medical School. My area of expertise and interest is the treatment of acute myeloid leukemia, and I run clinical trials of novel therapies in this disease. I was asked to discuss upfront management approaches for acute myeloid leukemia. Generally, when we consider the treatment of these patients, we consider fitness, functional status, comorbidities, and based on this, we determine if a patient is appropriate and eligible for intensive cytotoxic induction chemotherapy approaches, which have been around for 3 decades or more. The most common induction chemotherapy regimen in the United States is a regimen called 7+3, which is 7 days of infusional cytarabine, with the first 3 of those days incorporating an anthracycline, either idarubicin or daunorubicin. This induction chemotherapy leads to approximately 65 to 70% likelihood of remission by the end of the induction period, which is around 30 days of being in the hospital, where the patients are monitored closely. They get, obviously, treatment for the first 7 days. Their blood counts go down, their marrow becomes aplastic, they become transfusion dependent for several weeks. If they have fevers, they get antibiotics. After 30 days in the hospital, typically there is count recovery, especially if the patient is entering a remission. A bone marrow biopsy is done shortly thereafter to document remission, and then they go on to get consolidative approaches with either chemotherapy or a bone marrow transplant in an effort to cure them. So this paradigm, this approach to the treatment of newly diagnosed AML is a 2-step approach. The first step is this induction intensive chemotherapy in an effort to achieve remission. And the second step is called consolidation, which can either be additional chemotherapy, usually in the form of cytarabine, high dose or intermediate dose, or a bone marrow transplant, a consolidated bone marrow transplant. The goal of consolidation is cure, the goal of induction is remission. So that is the 2-step approach for the treatment of the intensive treatment of AML patients, the newly diagnosed setting for those who are eligible for it. For older patients who are less robust, or for younger patients who are less robust or who have functional status which limits our ability to give them intensive therapy, or have comorbidities which limits our ability to give that treatment. In recent years, we've started to use a gentler form of treatment with a combination of a hypomethylating agent, either azacitidine or decitabine, plus the oral BCL2 inhibitor venetoclax. So this combination of hypomethylating agent, HMA, plus venetoclax is now used predominantly for patients who are older or have comorbidity with AML. It's the alternative to intensive therapy in these patients. Whether this combination will in time also be used in younger patients or more robust patients is unclear. An additional study is needed, but the combination also leads to a composite remission rate of around 65 to 70% in phase 3 studies, which is very promising. One last thing I will say, the approach to the treatment of upfront treatment of AML oftentimes does require some molecular results to be available. For example, if a patient has a FLT3 mutation, we oftentimes incorporate FLT3 inhibitor therapy in the form of midostaurin and add it to 7+3 induction. If a patient has a core binding factor alteration, which is either an inversion 16 or an 821 translocation abnormality, typically we do incorporate the antibody drug conjugate against CD33 called gemtuzumab ozogamicin during the initial days of induction chemotherapy. So oftentimes it is important to know the molecular data relatively early before you start upfront therapy for AML. Thank you so much for your attention.